Hello, I'm Joe Schwab from Mass General in Boston, along with Larry Lowe, neurosurgeon from Northwell, and Dan Sciubba, chief of neurosurgery at Northwell. And today we're going to be speaking about spinal deformity as it relates to oncology. Larry, what role do you consider spinal deformity when you're approaching oncology patients, say specifically in the primary setting?
Okay, I think that as sort of our adjuvant treatments improve and patients are surviving longer and longer, we're actually able to achieve surgical cures for these patients. And what we've seen a lot is that they suffer complications from the fusion itself rather than the tumor recurrence in the setting of just sort of stabilizing across where we created iatrogenic instability. So what we find more and more is that even for our primary tumor patients, that they're all getting standing scoliosis x-rays or EOS x-rays, and we're actually using a lot of deformity principles as we take the tumor out. And it's just not just the tumor operation, but both tumor and also deformity element, addressing their underlying spinal deformity.
So in your planning, in terms of instrumentation, but also in terms of rod contouring and patient position?
Absolutely. So there was a memorable case that we did a few years back where there was an L5 chordoma, and the patient had a really, really bad sort of coronal plane deformity. And sort of our standard approach would have just simply been like an L3 or an L2 down a pelvis. And we spoke about the case, and we're like, this patient's going to live a long time. So if we do our standard lumbosacral pelvic fixation, we're probably doing the patient a major disservice. So at the same time as the oncologic operation, we also kind of straighten the patient out and stop the fusion at the lower thoracic spine, which is something that we typically would not have done, at least in the primary for a primary L5 chordoma. And I do think that seeing patients break down from older operations where we didn't take these deformity principles into account, certainly I'm not saying that every sort of lumbosacral tumor should be a T11 or T10 pelvis fusion, but it is something to think about.
Absolutely. One of the things that we've talked about quite a bit here is the treatment of patients with myeloma. And Dan, I wonder if you could expand upon that in terms of what are you seeing in patients who have these kyphotic deformities with myeloma?
Yeah, it's a great question because kind of platform or springboard off what Larry said, some of the biggest drivers of patient satisfaction or dissatisfaction are their alignment goals, which we hear this every meeting with deformity. We actually hear that even a T-lift should be a deformity operation, right? You don't want to flat back a patient. Yet when we sit there and a patient, by the grace of God, has myeloma that's treated and maybe a bone marrow transplant, all these things, the patient has a long-term survival, yet they have 10 levels of kyphotic fractures, of pathologic fractures, and you sit there and tell them you're doing great, these patients are in horrible, horrible condition. Now that doesn't mean, again, that every myeloma should be operated on. That doesn't mean that every patient with cancer should be considered a should be considered a deformity operation. But I think as we live in the cancer world and in the cancer hospitals, and we, for lack of a better term, pat ourselves on the back when we have a success oncologically, that the patient comes in and has a chin-on-chest deformity or a big cervical kyphosis, and they really are suffering a great deal. That what we're doing now is we're taking our step back, and we're not just looking at a cancer control, which in theory should be everything, or maybe a neurological benefit, which is everything. Deformity is up there, because if we get what we want, and they live a long time, and they're neurologically intact, they are only going to be complaining about their poor quality of life based on that. So when we think about myeloma, I think it's an archetypal case, because you could have many, many thoracic fractures, and the patient is bent over like a hunchback, and they're told, nothing to do, congratulations, you're doing well. I think that's going to change the paradigm. We got to think a little bit more broadly.
I completely agree. Larry, what you were saying earlier really resonated. I have a patient, say, that comes back, and I'm so happy, and they're happy that they don't have any cancer, but they're in terrible pain, right. And they have a positive sagittal balance.
Right.
And the problem that I have at that point is, I think, well, now I can do a deformity surgery after I've already done this other surgery, and right. They don't want any part of it.
Right.
And because it's fairly morbid, but. How do you manage that when you see a patient that comes back, and maybe it's my patient that goes to see you because they've got a spinal deformity? How do you balance that? You're going to put them through another large operation and try to correct their deformity. How do you have that discussion?
I think that for the most part, the patients, it's a very unique group of patients because they're actually very happy at their oncologic outcome, right? And they don't actually blame you or the surgical team for like the pain that they're experiencing as essentially a complication of the fusion itself. So I think that for the most part, my experience has been that we're starting off with very good equity. These patients are very happy with how they're doing. They're presumably seeing you a couple of years out from the surgery because they're doing well. And I think that it takes some convincing, of course, to talk about sort of we have to do a 3-column osteotomy or extend your fusion and whatnot. But I feel like for the most part, if you have a good sort of doctor-patient relationship, I feel like they're very open to the idea of sort of another secondary deformity operation to try to improve their quality of life. I feel like back in the day where we used to do sacrectomies on the Andrews table, right? I feel like regularly we would see patients a couple years out and we flattered them so poorly at their lumbosacral junction that, I can't stand up straight. I'm tumor free, but I can't stand up straight. And I think that those patients invariably got an extension of a fusion. And I think that those patients did very well long term. So I think that because as I'm growing my practice, I feel like I've seen more of these complications. That's definitely a concept that, at least even when I was training, that was not a concept that we even talked about where, you have a patient with sacral chordoma. Let's not make sure that we flat their lumbosacral junction, right? That's something that we never talked about. I don't think these patients ever got standing scoliosis x-rays.
Yeah, no, I think that's absolutely true. And clearly, Dan, with your tremendous experience in deformity, you were probably thinking about this earlier than most of us, probably certainly more earlier than I was, but that's not something that I was considering. And I was thinking about the tumor. It wasn't until after people like you had kind of identified this other problem and explained this to us that I started to see it. When did you start to really consider it in your preoperative planning and in your in techniques?
Yeah, thank you for that question. I think for me, Joe, and maybe this has happened to both of you as well, I feel like there's an infinite way that we treat patients, but for me, I'm starting to see patterns in my own practice, and I find that the metastatic lesions, I try to go smaller. I've been going smaller and smaller because we have usually some adjuvant treatments that respond. Maybe they're frail, maybe they're at an extreme point of their journey in cancer, and maybe I'm more willing to say we're not going to, boil the ocean. We're not going to fix every single alignment parameter because the cost is too much to them. But what I saw is when I had these primary tumors that we had somehow given long-term control to, they looked like my deformity patients. They were a different patient. Even though they both had cancer, they looked more like the deformity patients because they were sitting there going, yeah, another study with no tumor, and that's cool, but what about the fact that I'm crooked? What about the fact that I'm stooped forward? And I saw that as we were collecting data for deformity patients on all these quality of life factors, the quality of life factors we were asking for the cancer patients were, are you nauseous? Are you sick because you're taking chemotherapy? The primaries looked like the deformity patients. And so I found myself going, this is the driver here. And you can hope and you can put your head in the sand and say deformity doesn't matter in these patients. But as I said before, if you get it right and that you're lucky enough to get a long-term survival, they will start complaining to you about lack of flexibility or a junctional issue or hardware failure, which is the same thing in deformity, broken rods. And I remember it sounds terrible now, but I used to say to patients, congratulations, you got a broken rod. That means you've been out for so many years, right. And that's rude. That I meant it to say that we've been taking care of you so long. But now I look at it going, I can't believe I said that. This is terrible. We should be treating them and hopefully having a long-term durability. So I guess the answer to your question is, the primaries look more like the deformity patients than they even look like the metastatic patients in my experience.
Yeah, that's a good point.
And I don't know if you guys feel this way, but I even feel like for the oligometastatic patients or the solitary metastases patients, they behave a little bit differently too, right? I think that traditionally for a metastatic patient, we never even considered like, it's really kyphotic at the thoracic apex. Let's just decompress and put in a cage possibly and then get out of there, right? And I think that for the patients that are oligo or solitary metastatic disease, I think that although you can say that it's not a direct correlation, but part of the reason why they have that rod fracture a year and a half out is because their underlying kyphosis or deformity wasn't addressed. So you can even make an argument that sort of like the early hardware problems that we're seeing from the sort of the metastatic operations are definitely an element of an underlying deformity issue that led to that possibly.
That's a good point. I've been blaming all my rod fractures on radiation, but apparently maybe it's my surgery after all.
You know, one thing to think about as we kind of go into this, that just as we're bringing this up and people are going to think about it more, maybe with this event today, is also to be conservative, though, in the fact that what I don't want to see in the tumor population is what I saw happen in the degenerative population, where patients had lumbar stenosis and were bent a little forward because they were auto-decompressing themselves. And maybe it wasn't a real flat back, it wasn't a degenerative flat back. It was just an antalgic position where they would find themselves, and people would put up a scan on a standing film and say, T10 to pelvis because we need to restore the alignment. When in reality, they might just need a decompression. What I hope we don't make the same mistake as we kind of go into this new area is we don't see every tumor patient as a massive chance to do a perfect alignment, because the stakes are high in the degen population, the stakes are high in the deformed population, the stakes are even higher in the deformed tumor population. So we should walk lightly, but think about these things, and hopefully that together we can make some good judgments on these issues.
Absolutely. Yeah. Thanks very much.
Thank you.